the isotope, putting seeds in the prostate.
Oh, you're talking about brachytherapy?
Yeah.
The seeds are themselves have the isotope, which deliver. We don't do a lot of brachytherapy in Mathew anymore, so I can't remember off the top of my head how long the radiation lasts within the seed. But the seeds are placed. It's basically innumerable seeds to deliver small amounts of radiation to encompass the whole prostate gland. So they're placed transperineally typically, so not transrectally because there's too many sticks to put it in. So.
What was the reason why you stopped doing it?
The reason why we stopped doing it,
Yeah.
it was very in vogue in the 90s and 2000s, and then external beam radiation therapy, which our radiation oncologists superseded because if you think about it, your prostate gland is a dynamic structure. When we all breathe, the prostate moves. They used to tattoo people and then just shoot the radiation externally into generally where the prostate was. You have scatter, you have bladder side effects, you have radiation cystitis, radiation proctitis. Now we place the calypso beacons, radio frequency beacons within the prostate, that as the prostate moves, the external beam of radiation, the machine can stop and wait till it comes into field and hit it then, rather than just kind of blindly hitting it. So it's getting more and more precise.
Gotcha.
That's why we've
sense,
gone with that. But brachytherapy is a good option for some patients. It's very center dependent. There are other DoD facilities that do brachytherapy. If I have a patient that wants it and is a good candidate for it, we send them out to the community to do it. So we don't withhold it just because I don't use it a whole lot. It's a very good option. It just fell out of favor within our population base.
Yeah. What correlation, if any, exists between prostate cancer, bladder cancer, and perhaps colon cancer?
So prostate cancer is really going to be hereditary. Colon cancer, bladder cancer, there are different familial syndromes. There's not a big association between bladder, prostate, and colon, other than, again, kind of that idea that if you are born and certain genetic tests that are available to see what are your cancer suppression genes, some people are more likely to have tumors. I have patients that have had 3-4 different type of cancers. They don't have any named syndromes. They just have more or less bad genes for it. But there's not a syndrome that encompasses all of those 3, or at least hasn't been diagnosed yet.
The best thing about my recent colonoscopy is when the doctor said, "I'll see you when you're 80." I said, "I hope so."
Yeah, absolutely. No,
That's a 5-year.
That's a 5-year. That's great. That's great.
I have another question.
Absolutely.
Can you describe a spasm of the bladder? Sometimes I wake up at night and I feel a real short tightness above the pubic bone area.
Sure.
I don't know if that's a spasm or what's going on.
Yeah, so bladder spasms, it can be suprapubic tenderness above the pubic bone. Kind of you have it feels like a cramp or a Charlie horse in that area. Often involved with people who have leakage at the same time, because as the muscle squeezes, a little water goes over the dam and kind of comes out. So that's one thing that they'll notice as well. Those are primarily the symptoms that you're going to have, or some people don't have the actual pain part. They just say, I leaked kind of unexpectedly, and that could be a bladder spasm as well. But there's also other things, rectal spasm, other things that are, indigest, other things that can be causing that muscle, rectus sheath pain, other things that can mimic it as well. But it's typically leakage and then kind of a squeezing sensation.
Speaking of leakage and incontinence, does Madigan do the sling procedure? There's a sling. What else is there? There's the one that
Artificial urinary sphincter.
Yeah.
Those are the two most well-studied incontinence devices. As you do research on that, there are some people that will talk about urethral bulking agents, so injection of polymers within the urethra, basically to kind of close the valve up. That doesn't work very well, so we don't use it. The sling works well for men with I say lower volume incontinence, maybe 3 or 4 pads and no radiation history. If you've been radiated and you have high volume incontinence, the sphincter is your best bet. Because once the radiation gets into the urethra, it's too stiff and the sling is going to not work very well.
My personal major issue is when I'm sitting for a while or when I'm driving for a while, when I stand up or get out of the car, I know exactly where I have to go.
Yep.
Sometimes I make it, sometimes I don't.
Yeah, exactly. I see some of my elderly patients move very quickly to the bathroom when that hits. So.